Alrighty, hello everyone. Thanks to all that are joining online and in person. My name is Milka Puthakari. I'm an MS2 and the president of the Project Echo elective here at the TTUHSC School of Medicine. I would like to welcome you to Project Echo, a program that Dr. Santos and Dr. George founded. The initiative hosts monthly sessions with specialists from our Health Sciences Center to educate primary care providers in the rural and underserved areas of West Texas. The goal is to address key metabolic and health disparities through case-based scenarios with hopes of reducing unnecessary referrals, labs, procedures, and ultimately drive down healthcare costs for our patients. You may occasionally receive emails from our Project Echo team inviting you to host a presentation or participate as a panel specialist in the future. Please keep an eye out for these exciting opportunities. And then next slide, please. Before we begin, a few quick reminders. If you're attending online, please stay muted throughout the presentation. CME credits are available for this event, but you must complete the evaluation survey at the end of the presentation. We will have a reminder for this at 12:55. For those attending in person, please ensure you've signed in on the paper at the front or the back. This educational activity is supported by the Texla Telehealth Resource Center, a federally funded program of the F. Murray Hall Rural and Community Health. Now I'd like to hand it over to our second-year medical student, Christian Bell, who will be presenting alongside Dr. Depphak Swaminath. Thank you.
Good afternoon, everyone. My name is Christian. I'll be presenting our case for today. So our patient is a 55-year-old female who presents to the emergency department with tachycardia and heart palpitations that has started suddenly earlier that day. She denies chest pain or shortness of breath. Her past medical history includes atrial fibrillation with rapid ventricular response. She has status post transesophageal echo and DC cardioversion 3 different times, with the last cardioversion being 4 days prior to this encounter. She also has a history of congestive heart failure with a recent ejection fraction of 40 to 44. She has hypercholesterolemia with a recent LDL of 142, type 2 diabetes with a recent A1C of 5.6. Past surgical history includes a hysterectomy and abdominal wound drainage. Her social history is unremarkable and has no known drug allergies. Her medications include amiodarone and metoprolol, although she did skip these medications the day of the event. She's also taking apixaban and torsemide, although she's only taking about half the prescribed dosage due to confusion. She's also taking spironolactone, metformin, and Ozempic. Next slide, please. Her vitals today were blood pressure of 114/66, heart rate 167, respiratory rate 24, temperature 98.7, a height of 157 centimeters, weight of 119 kilograms, which puts her at a BMI of 48.6. O2 sat was 97 on room air. Her physical exam showed an irregular rhythm with non-pitting bilateral lower extremity edema. All other physical exam findings were not important. Here was a representative EKG upon admission. Note the sawtooth wave pattern in most of the leads. Next slide, please. Assessment and plan for this patient. This patient is diagnosed with atrial flutter with rapid ventricular response. The patient was admitted to the hospital overnight where she continued amiodarone, metoprolol, and apixaban on the correct dosages. An EP consult the next day recommended a radiofrequency ablation. During this procedure, they first conducted a 3D mapping of the heart circuitry, followed by several ablation techniques. They started by ablating the earliest activation site, which ceased flutter immediately. They also performed a posterior wall isolation, a cavo-tricuspid isthmus line, and ablation of the right carina and left ridge. She was discharged the same day and continued her home meds with the correct dosage. At this point, I welcome Dr. Swaminath to take over this presentation. He is the Director of Electrophysiology, Program Director of the Electrophysiology Fellowship, and Associate Professor at TTU-HSC School of Medicine.
Hello, everyone. Thanks for the invite. Sorry I couldn't be there in person because it was a last minute. We were catching up stuff, so we couldn't make it in person, but I'm glad to give you the presentation on atrial fibrillation management. So if you look at the atrial fibrillation management guidelines, you can start from the first guidelines came was in 2001. And subsequently, we had multiple guidelines, 2012, 14, 2019, and the last one was 2023. So if you look back, in 1991, the first thing they found was it was based on a Framingham study that patients who have AFib, they seem to have five-fold increase in stroke. So that was the first study that kind of gave importance to atrial fibrillation. Subsequently, what they did was they tried to prevent those strokes. So they tried aspirin first, and then they tried warfarin. So the whole decade was trying to find which anticoagulation is better. Of course, in 2001, so if patients had AFib, then anticoagulation was, prescribed and it was recommended. But from 2001, there was a lot of newer anticoagulation medication like apixaban, rivaroxaban, dabigatran, edoxaban. So all these new medications started coming from 2001. Let me go back, sorry. So since 2014, we saw a lot of newer anticoagulation coming, and they found it is much superior to warfarin. But also during the same time, back in 1999, what they found was if there is an AFib, is that a trigger within the heart that can cause atrial fibrillation? So what they found was in the lab, they found that those pulmonary veins that are on the left atrium has triggers for this atrial fibrillation. So from 2001 to this next 2 decades, they worked on perfecting the ablation technique to isolate those veins. So the more and more they started doing ablation, they did realize that it helps to prevent progression of these atrial fibrillation. So do we have to do ablation on everybody? No. So that's why we have guidelines on which populations benefit the most. So this entire presentation, I'm going to be focused on what's the current guidelines, from AHA and HRS that was published in 2023. We're also going to look and see what are the research that actually helped us to come to the final recommendations. So if you look, is atrial fibrillation a problem? Yes, it is a big problem. And you can see the incidence of AFib is going to be more, in the next few decades. And this might be partly because of a lot of risk factors like obesity and uncontrolled hypertension, and also heart disease. And as you know now, we have much advanced therapies for, CAD, so they live longer. So the longer they live with the CAD, they tend to have atrial fibrillations and other disease along with CAD. So what is the significance? Why is AFib very important? Because it increases your risk for stroke to 5-fold. And also it increases your risk for heart failure. There is a link of increased risk of sudden death. And also there are about 500,000 hospitalization because atrial fibrillation. And the cost is also very high, cost them about 26 billion increase in US healthcare cost. So now let's look what AFib is, okay? So here you have 2 EVMs from a device. The one on the top, you can see that atrial lead, and you can see this ventricular lead that's tracking the impulse. So as you know that, impulse starts in the upper chamber. So you see a spike here, and then followed by a spike in the lower chamber. So there is atrial contraction and there is a ventricular contraction. This is what happens during sinus rhythm. So what happens if this patient goes into AFib? So that's the one that you see on the next EGM, which is below here, you can see that the atrial lead is showing high electrical activity, right? So that tells me that right now the rate of the atrium is about 300 beats per minute. And then you can see that this patient, of course, has a low ventricular response. So the ventricle is being paced by the pacemaker. So now we know what the electrical problem is. So what happens when you have an electrical problem is followed by a mechanical problems. So what happens, your atrium is now not contracting, they're only fibrillating. So when you do that, what happens is you drive the ventricle a little faster. So the heart rate is about 150 beats per minute because AV node protects the lower chamber from getting all the impulse. So your heart rate is somewhere between 150 beats to 200 beats per minute. If that patient has that heart rate for 4 to 6 weeks like that, they are at risk for developing heart failure. So that's one big problem. The other one is you don't have a good contraction, right? If your heart is beating at 300 beats per minute, then you're probably they have no good quality contraction. So what that happens is, especially patients who have diastolic dysfunction, they depend on atrial contraction for their cardiac output. So those patients become very, very symptomatic. So how does the symptoms manifest? We saw electrical problem, then we know what's the mechanical problem that happens. So what is the symptoms that comes out of it? Of course, one is heart failure. Then you have palpitation, chest pain, and stroke, and fatigue, and shortness of breath. So let's see the symptoms in detail, because symptom is very, very important. Because all those advanced therapy that we are recommending now is only for patients who are highly symptomatic. So it is very important, like a primary care physician who sees this patient should evaluate for these symptoms. The one common mistake I always see that they do is they think that palpitation is the only symptoms that AFib should have. That's not true. So they could have shortness of breath, fatigue, and extreme tiredness. So this becomes very challenging on an 80-year-old or a 75-year-old, right? So when they have extreme fatigue and shortness of breath, it could be multiple reasons. So how would you pinpoint it's because of atrial fibrillation? So the one thing that we do is we cardio with the patient normal sinus rhythm. Once the patient is in normal sinus rhythm, we assess the symptom. Has your symptom changed or not? So that will give us an answer to how aggressive we are going to treat this atrial fibrillation with rhythm control. So this is very, very important. So assessing the symptom just for palpitation does not mean that patient does, it does not mean that they don't have any other symptoms. You have to ask the patient of shortness of breath, fatigue, and tiredness. If they have, they should have a trial of cardioversion, and then symptom needs to be assessed if it has improved or not. So how did the guidelines change over time? So the guidelines before they classified AFib more like based on duration of how long they had atrial fibrillation, but the guidelines currently recommends that AFib is a disease of continuum. So there are patients in different stages, and those treatments have to be tailored depending on what stage they are in. So what are the classification right now on atrial fibrillation? So there is four major classifications: at risk for AFib, pre-AFib, and AFib, and permanent AFib. And the patients who have AFib, they are further classified into paroxysmal, persistent, long-standing, and also there is a bracket now. We have successful AFib ablation as one of the stages of atrial fibrillations. And also we have permanent AFib. Depending on what stage they are in, we tailor the treatments based on their stages. So what is the real problem what is causing this atrial fibrillation in, from cellular level? So there are three important things that we need to note. So one, increased calcium overload happens within the cell molecules, and that changes the refractory period of the atrial muscle that creates a reentrant circuits and causes AFib. When you have chronic stretch, that also creates a lot of fibrosis and can cause reentrant circuits. And so these are the main reason why patients tend to go into atrial fibrillation. So if you look, this is kind of a diagrammatic representation of AFib. So you can see here, this is the right atrium and this is the left atrium, and you can see there are multiple wavelets can cause AFib, or a single focus can cause an AFib, or a single reentrant can cause AFib. I have few slides towards the end to show what we do in the lab. Hopefully we have enough time for me to show those slides, which shows the 3D mapping and the ablation that we do. So what about the management? What is the what big changes have happened in the management of AFib? So when you have a patients with AFibs, our approach is, it's like 3 pillars of management. One, the stroke risk, okay? The another one is to optimize the risk factors. And the third one is symptom management for the AFib battle. So those are the 3 pillars of management for atrial fibrillation. So let's look at each pillar a little more in depth, and I will also try to explain how over the last, like 2 to 3 decades, this has changed, and based on what research findings did it change. Okay, so now we'll start with, first thing is the stroke rate. So this is a very important study. This was actually published in 1991. So when this was published, what they found was the patients who were in Framingham study, they found that patients who have coronary artery disease and hypertension, they had 2 or 3-fold increase in stroke incidence. But they also found in patients with AFib having 5-fold increase in stroke. So that really caught attention in 1991, and then realized that if patient is in AFib, then we need to worry about the patient's risk for stroke. So the next 10 years was trying to find what the solution is. So now, of course, we have a lot of newer agents. We're going to talk about all that in detail. So now let's say if patient have a AFib, how are we going to assess their stroke risk? So if their stroke risk is greater than 2%, then it's a class 1 indication that you need to consider for anticoagulation. If it is risk is 1 to 2%, then the risk of stroke, then it's okay to try aspirin. And so if, let's say, patient has a risk for stroke greater than 2%, what kind of anticoagulations would you try? So now the newer anticoagulations like, apixaban, rivaroxaban, they are the class 1 indication right now for anticoagulations. We no longer recommend aspirin and clopidogrel together to recommend for stroke risk reductions. So let's say, how do you understand? How do you come up with the risk? How do you give that percentage? Okay, this patient has 2%. How do you do that? So you use a CHA2DS2-VASc score. So based on the CHA2DS2-VASc score, if it is greater than 2, then you recommend, for men, you recommend anticoagulation. If it's greater than 3, you recommend anticoagulations. And if patients have any mechanical valve, then of course you have to use warfarin, but not the DOACs. And if your risk is between 1 to 2%, then you kind of have to, you still can anticoagulate. It is a class 2A indication to anticoagulate. Anything 1, I think aspirin would be the best option. So what happens, for example, this is more for cardiologists, because when they sometimes check a device, they will see that patient had some AFib, like 5 minutes or, sometimes 6 hours of AFib recorded in the device. if that happens, then usually if it's greater than 24 hours, we recommend anticoagulation. But if it is less than 24 hours, but greater than 5 minutes, then you need to assess the patient, see if they have any other risk factors that would increase their risk for stroke. For example, a previous history of stroke, or if they are very old, or if the CHA2DS2-VASc score is greater than 3, then you consider anticoagulation. Okay, so now what options do you have for if patients who have AFib? What medication do you try? If the patient does not have any bleeding risk, you can try, of course, warfarin is now, it's not a class 1 indication. You try apixaban or rivaroxaban, dabigatran or edoxaban. Let's say if patient has bleeding, if patient who's on dabigatran or in Eliquis or edoxaban, if they have bleeding problem, then we recommend left atrial appendage closure device. So let's see the studies that kind of supports these things. Okay, so if you look, this is a paper that was published back in 2007, and as you can see, the entire 1991 to all the way to 2005, all they did was they compared aspirin versus warfarin, because we just had only warfarin at the time. So when they found was that warfarin was much better than aspirin, and the all-cause mortality reduced to 26%. Then what happened was the patients who are in warfarin, their INR never was in range, and there was a lot of problems. So they started developing newer medications. Those are the apixaban, rivaroxaban, and dabigatran, edoxaban. So these are the clinical trials that kind of showed for each medication that they are either non-inferior or sometimes even superior to warfarin. So that's why we recommend now it's a class 1 indication to start a patient on Eliquis or apixaban or rivaroxaban, or we call Xarelto, because it's superior and it is sometimes non-inferior to warfarin. So there are certain populations that we pick certain medications. So if patient had some gastric irritation or anything, then apixaban is a drug of choice. If they are elderly, you can use any of those newer anticoagulation. If they have coronary artery disease, Xarelto is a preferred medications. Okay, but if they have mechanical valves, still you have to use warfarin. So these special population, especially patients who had recent PCI, sometimes they are on triple therapy. So, but the studies have proven that dual therapy is as good as triple therapy with a less bleeding risk. So now we recommend dual therapy with clopidogrel together with Xarelto for patients who have a recent PCI. So these are the trials that showed BOOST and Pioneer AF PCI, which kind of showed that it favors a dual therapy, not triple therapy. But still, we talk to the intervention cardiologist before we back any of these drugs. So what happens if you're in anticoagulation and you have bleeding? So then you have to stop the anticoagulation. But if you stop the anticoagulation, how would you decrease their risk for stroke? So now for those kind of patients, we came with the new techniques which call left atrial appendage closure device. So what is a device is you can see that in the left atrium, there is a small appendage where you can form a clot, and that clot can dislodge and can cause stroke. So what we came up with a device we call left atrial appendage closure device, or Watchman. So what we do is we put a catheter that goes from the groin, we do the transeptal and go to the left atrium, and then we deploy this Watchman right in the left atrial appendage. It takes about almost 6 weeks. It completely seals this whole appendage. So once it is sealed, and what they did was they did a multiple clinical trial to compare it with warfarin. So these are the two big trials that have shown PROTECT AF and PREVAIL trial, which showed its safety and its efficacy. So when compared to warfarin, they had similar, they were pretty much equal to the newer anticoagulations in protecting the stroke. And you can see that patients who had this Watchman were benefiting same like as if the patient was on any anticoagulations. So what we do is once we put the stent in, we put them on aspirin and Plavix for like 5 to 6 months, and then we stop the Plavix, and the patient will be only on aspirin the rest of their life. So we have enough data, 5-year outcomes from the meta-analysis, which clearly shows that they are not inferior to the anticoagulations. That means you can consider for patients who have bleeding on blood thinners, you can consider left atrial appendage closure device. So now let's jump a gear and discuss about the next pillar of AFib management. So you did a stroke analysis, you found patient needs anticoagulation, you start them on the blood thinner. The next step is, okay, what about their risk factors? Because risk factors play a major role in atrial fibrillation progression. So if you control these risk factors, that means you control the progression of atrial fibrillation. So do we know what are those risk factors? There are not many. And usually it is either hypertension, it's obesity, sleep apnea, and lifestyle like alcohol consumption and sedentary lifestyle, or those are the modifiable risk factors. So what happens when you have diabetes and obesity, hypertension, and sleep apnea? They tend to form fibrosis in the left atrium. That in turn causes conduction slowing in the left atrium and changes the action potential duration. When you have high sympathetic tone or high vagal tone, it can change that, and that could lead you to have atrial fibrillation. So is it just a theory? No, actually what they have done is they did study, they did you can see here, these are a control group, these are hearts. We did voltage mapping. So what we do is we put a catheter and track the voltage within the heart and see how healthy the heart. So the more red you see, it's unhealthy. So you can see patients who have hypertension, heart failure, they tend to have scars, which are those red zones. And they realize that if you have these risk factors, you tend to have increased scar, and that leads you to have more AFib. So can you reverse this if you can reverse your risk factors? Yes, actually, there are a lot of studies that's proving that, and which we are going to show you next. So the guideline says that if you have patients with AFib, you encourage them to have exercise at least 30 minutes, 3 times to 4 times a week, and also control the lipids and treat the sleep apnea and control the hypertension and the diabetes. So these are the clinical trial that was done to see. So you can see legacy. What it does was it just looked at weight reduction. So you can see the more weight you reduced, you have better freedom from atrial fibrillation. Then what happened was they combined ablation together with exercise, and they realized that it works even better if you have, combined together. The freedom from AFib goes down for patients who had ablation and had a rehab where they focused on weight loss. Then there is a CardioFit, another trial that looked at it, weight as well as the METs, the fitness, and the big impact was seen on weight loss together with increased fitness. And that's why now it's a class 1 indication for patients who have AFib to undergo weight loss. And we usually recommend them after an ablation. The reason we do that is because patients have symptoms. If they have symptoms, they are not going to go and run and do exercise. I think when you do an ablation, it controls their symptoms much better, and they gain confidence and they start exercising. And once they lose weight, and their progression of AFib really stops after that. So let's see the next pillars of AFib management, which is the symptom management of atrial fibrillations. So when you have AFib, so do we have to do a rhythm control or rate control? Because I would say back in 2000, the rate control was the big, if patient had AFib, the only option was to do a rate control. I think, over time, multiple studies have shown that if you have symptoms, you have to have aggressive rhythm control strategy. I think rate control only for patients with asymptomatic patients. If they have symptoms, you need to try rhythm control. Whether your rate or rhythm does not change how long you live life. The patient's mortality does not change, but the quality of life is better when they have rhythm control. So that's why in all the guidelines now, rhythm control is emphasized a lot. So this, you can see here about if you do a good rhythm control, then the progression of AFib, you can see that they did a study where they did a rhythm control. There's 11% of them progressed in AFib. The progression happened in patients with rhythm control. If you just rate control, their progression is much faster than patients who had rhythm control strategy. So you don't want them, the AFib to progress and they become a permanent AFib. So I think that's one of the reasons we recommend rhythm control is to stop the progression of atrial fibrillation. So how do you do the rhythm control? One important point here in this slide, as I said, rate or rhythm control, you're not looking at the mortality. Mortality it's not going to change. What's going to change is their quality of life. So if you do an ablation you can do a rhythm control with both ablation as well as with the medication, depending on what stage of AFib they are. In the earlier stage, actually medication works as good as ablation. But as you go over to persistent AFib or even long-standing persistent, I think medication success rate drops down dramatically from 60% all the way to 20% or 30%. So as you know that ablation also over past 20 years, as we have gone through a lot of transformation in ablation techniques, in mapping techniques, and it has shown that the catheter ablation is much safer than it used to be because we tend to do a same-day discharge on these patients. So the risk of any complication happening is, it's less than 1%. So it's cost a lot safer, and it has proven to be better than medication when looking at the AFib recurrence. So when you have medication, what medication you can try? So it depends. We have to look at the patient's overall, picture of the patient. You have to look at the comorbid conditions. If patients had CAD, then we don't use flecainide or class 1 medication. The options are class 2 or 3 or even 4. But patients with no CAD, we do prefer class 1 medication, which is flecainide or propofenone. And it's very common. I see everybody in the hospital using amiodarone. I'll tell you, amiodarone is the last, if you even the guidelines you can see that it's the last options that we try because of their risk profile. A lot of side effects from amiodarone. There is not one organ that it does not affect. It affects the eyes, it affects the skin, it affects the thyroid, it affects the liver. So we tend not to use it. We only use it on patients who are older than 80 years. The thing is, by then, for this drug to cause side effects, it takes 3 to 4 years. So on older patients, it's reasonable to try amiodarone, but on younger patients, we don't recommend amiodarone. So you can try sotalol or dophytalide, for which patient needs to be admitted. It can't be done as an outpatient. So I think usually we do the loading and we send the patient home on after monitoring for almost 48 hours. But you can try outpatient. You can try dronidone or flecainide or propofol. Those are good medications for AFib, paroxysmal AFib. So this kind of diagram shows you if you don't have any structural heart disease, you can pick and choose any drug you want. Okay, and as you know, amiodarone in all of it is the last thing that we give. It's not the first one. Sometimes we give amiodarone on post-op AFibs. It's a good medication for post-op period, but it's only for 3 months. You just have to make sure they don't refill after 3 months, because what common thing that we see is the patient have AFib after a procedure, and then they put them on amiodarone, and then patient is on amiodarone for next 5 years for no reason. The best course of treatment for those patients who have post-op AFib is to try for only 3 months, a short duration of amiodarone, and then we stop it. So rate control. So this is the trial that kind of showed that there is no mortality benefits whether you do rate or rhythm. So this was back in the early 2000. This study came out, and people started rate controlling everybody. But what they missed was the quality of life and the symptom and the progression of AFib. So after this study, there was multiple study that has come out, which now proves that rhythm control is much better and safer. And when you control the heart rate, what is the number that you want to focus on? So either, you don't need to have a strict heart rate control below 80, anything less than 110 is fine. This is the RACE 2 trial that clearly shows that there is no big difference how aggressive you control the rate, but you don't want, this should be when they are exercising, just make sure at rest, they might have a low heart rate, but when they exercise or move around, their heart rate might increase 150 or something like that, then you have to, aggressively control the rate. So the treatment, of course, beta blockers. If you have a low LV, EF, then don't try any calcium channel blocker. You can try digoxin. So different types of beta blockers. There's not one specific. You can try all of those. So rhythm control with ablation. So what do we do during rhythm control on ablation? So what we do is, here you can see that the left atrium, you can see there are 4 pulmonary veins. Most of the trigger points for the AFib are on these pulmonary veins. So what we do is we try to do ablation around those veins. So we can do 3 different types of ablations. One, we do this thing called cryoablation, where we cool the tissue, and by cooling a tissue, you create you kill those tissues, and then they are not electrically active after that. So that's one form. The other one is radio frequency, because you send a radio frequency thing to the catheter, it heats up the tip, and you create a lesion because of thermal effect from the heating. But now, recently, in the past 2 years, we have a new thing called pulse field ablation, where we don't do, this is a non-thermal way of ablating. All you do is you just send a high electric current into that vein, and then it shuts down all the pores. And by shutting down all the pores, you don't actually create any damage to the muscle, but all the ions and channels get completely damaged. This ablation, this way of doing this pulse field has decreased our complication risk to actually less than 0.25%. So it's much safer than the RF and cryo. So now we are using, and especially in our lab, we do a lot of pulse field ablations. So when we do ablation, what we do, we just isolate the veins. Sometimes we look for non-PVI triggers, which could be in the posterior wall, or it could be in the veins in the superior vena cava or in the coronary sinus. And we do ablation in those places if we find any triggers. So right now, the indication for AFib ablation is it's a class 1 indication for patients who have AFib on antiarrhythmic medication. And it is also an indication if the patient have high symptoms. It's a class 1 indication. It can be tried as a first line of treatment. And you don't try to do an ablation on a patient who had either a permanent AFib or a long-standing persistent AFib. For those asymptomatic patients, ablation is not recommended. Only for symptom management, we use these ablations. So as you know, that freedom for paroxysmal AFib, the success rate of ablation is higher. That's why we say, you know, earlier you do the ablation, it is better than the latest. And for persistent AFib, our success rate is not as good as paroxysmal AFib. It takes, you know, that's mainly because it's just not only the pulmonary veins, but we have to focus on, we have to do additional ablations on non-PVA triggers, which still for us, it's an unknown territory and we're trying to work on that. Hopefully we'll have further solution in the next few years to come. So is ablation safe? Yeah, it does. It is safe, but it does, you know, it's very important you talk to the patient about the complications. You could have, you know, complication like a fistula, whereas in pulse field ablation, there is no way you could have a fistula. The perforation rates are all low because of the, you know, we use ultrasound techniques and the risk of perforation has gone tremendously. There are risks for stroke, infections, and you know, vascular access complication. That's still there, but those are all less than 0.5%. So patients with heart failure, they tend to have benefit more from atrial fibrillations. So if you look, patients, this is a study that did try, you know, on patients with heart failure and AFib. They did a catheter ablation. They looked at the mortality, and of course, patients who undergone catheter ablation have a higher benefit than the one that had a medical therapy. And there is also a study called camera MRI, which kind of looked at not the mortality, but looked at if the EF will improve after an ablation. And they compared with the medical therapy. There was increase in about 20% in ejection fraction after an ablation on those patients. So on patients with a heart failure and AFib, we are very aggressive in restoring the rhythm. And ablation is the best way to restore the rhythm in those kind of patients. And the younger they are, we do recommend ablation. So the final recap on the patients on the 2023 guidelines, early rhythm control is recommended. And, you know, ablation is a class 1 indication and it's a first line treatment now. And NOACs is recommended over warfarin. Make sure you check renal panels and hepatic function on patients who are on NOACs. Left atrial appendage is a consideration for patients who have bleeding on who are on anticoagulations, and AFib ablation on heart failure patient and young patient is beneficial. Weight loss is recommended. That's a class 1 indication. So thank you. And I want to show you a few slides. I don't know if you have time. I think maybe 2 minutes or 3 minutes. I'm going to show some PowerPoint that we on ablations.
There it goes.
Okay, so let's go back. Okay, but a little bit fast. Okay. So this is what I was showing. Okay, so these are the electrodes that you're seeing, and you can see a lot of, you know, these are electrodes within the heart that's showing that patient during AFib. You can see all those continuous fractionated signal that you see in the left atrium. Okay, so when somebody has that, what we do is, so what we do here is, when ablation, we put a catheter from the left atrium, from the groin, from the femoral vein, and we go up to the right atrium, and then we go to the left atrium by transeptal. Okay, once we cross the septum, then we do the ablation. So you can see there's 2 veins on the left. This is the left atrium. You have 2 right-sided veins and 2 left-sided veins, and we do ablation around those veins. And this has a success rate, and you can see that pre and post. When you see these are voltage map, we call. So when you say it's a pink, that means you have a good healthy voltage, and you can see post ablation you are electrically disconnected from the atrium. So all those triggers from the pulmonary vein cannot enter into the heart. This is one example. There's a patient who's like 60-year-old came in with tachycardia, And this is the right atrium, this is the SVC, and this is the IVC. You can see that there was a focus that's coming from the tricapside valve. We did ablation around here. Patient immediately terminated tachycardia and never had this tachycardia after this. And this is another patient who had an SVC ATAC. So we did a patient came in with an aerocomplex regular tachycardia at 170 beats per minute. So we did a mapping and we found that the impulse was starting from the SVC and it was coming down to the right atrium. So we found the trigger point for this tachycardia was here, and we found a fractionated signal that's over here, and we did some ablations around there, and tachycardia terminated. He never had recurrence for the past 3-4 years of this tachycardia. So this is an ATAC ablation, and so this is another ablation on a patient who had, who had a left-sided atrial flutter, and you can see the flutter waves, and we did ablation around those flutter waves where the tachycardia was in flutter, and it terminates at the end of ablation. Okay, I'm going to stop here so I can ask questions. If they have questions, please.
Thank you, Dr. Swaminath. We're going to do a quick recap, Christian, is about the telemedicine incorporation. Can you click on that? Yes, that one.
Just real quickly, I wanted to go over the importance of telemedicine in cardiology. First of all, it allows for enhanced diagnosis and monitoring by using wearables and implantable devices. We're able to get a real-time data from the patient, not only when they're in the clinic or in the hospital, also when they're at home and throughout their day. It also allows for improved access and efficiency. Obviously, remote telemedicine can eliminate the time and cost burden that patients have to take on in order to make appointments, and allows for more flexible care, allowing them to have more convenience and possibly more follow-up in their care. Finally, it can improve patient outcomes. Early monitoring allows us to detect worsening conditions before it gets to an emergent point, allowing us to have timely intervention and reduce hospitalizations. And does anyone have any questions for Dr. Swaminath? Thank you.
Wow, what a wonderful presentation. So thank you, Dr. Swaminath, for a wonderful presentation. Thank you all for attending today's Project Echo Grand Round session. Just a reminder to please sign in on the paper in the front and complete the evaluation for CME credit, and the evaluation will be due Friday. Lastly, if you would like the lecture materials from today, please register on the iEcho website to access the session materials. But other than that, thank you so much, everyone. We appreciate your time.
Thank you.